Okay, it looks like we have our participants in. I'd like to welcome you this morning to our trainee research award presentations. I'm Susan Vogelmeyer on behalf of my co-chair, Eric Hung. We are happy to welcome you today to hear talks by Alison Hwong and Kristen Rudd. Just to let you know the purpose of the Trainee Research Awards, this is the 9th annual presentation. The purpose is to showcase original research done in the Department of Psychiatry and Behavioral Sciences of advanced trainees in this high visibility forum in our grand rounds. So to remind mentors and mentees that the applications are in general around January and the presentations are around now. So next year, for those trainees who will be moving on to either their independent career or another phase of their training, please consider applying for the award next year. I'm happy to have our 2 trainees today and remind you that there's another 2 trainees next week who will present their work. Our committee, I'd like to thank the committee that also includes Steve Hinshaw, Andrew Crystal, Dave Manoli, Dan Mathalon, and Marina Tula-Shams, as well for choosing these awesome awardees who are going to talk to us about everything from basic science to health services research. And they represent many of our sites from the VA to Mission Bay to all the way out into the community. So with that, I'll just welcome everyone to this, and I'm going to turn it over to Dr. Christina Mengurian to introduce our first trainee awardee.
Thank you so much, Susan, and hi, everyone. It's my absolute pleasure to get to introduce Dr. Alison Hwong. For those of you who don't know her, Dr. Hwong has had a very impressive training background, obtaining her undergraduate degree at Brown and then getting an MD as well as a PhD in health policy from Harvard. And she actually had a brief stint at a university in Belgium in between for another master's degree. We were very fortunate to recruit her here to the UCSF Department of Psychiatry and Behavioral Sciences residency training program in 2016. During that program, she was part of the residency research track, and her research is focused on examining health disparities among people living with serious mental illnesses and other vulnerable populations, including those who are adversely affected by social determinants of health, including climate change and justice system involvement. I've had the honor of being her mentor since she was in that residency research track and have thoroughly enjoyed watching her grow as a physician scientist. She's a natural leader and was selected to serve as the chief resident of research during her last year of residency. And during that time, she actually started a Women in Science interest group for the research track. Dr. Hwong is also one of the inaugural fellows of the National Clinical Scholars Program at UCSF and the San Francisco VA, a prestigious national program led by Hilary Seligman. And I'll share a chat about that in a minute so that people can read more about this. On a personal note, in addition to her intellectual prowess, Dr. Hwong loves the outdoors. She got married on top of a mountain during COVID and regularly competes in marathons. She's done 13, including 4 ultra marathons. For those of you who don't know that, that's up to 50 kilometers or even 50 miles. She's really an incredible athlete and scholar. And I'm just welcome you, Alison. I'm so proud of you for this well-deserved accomplishment, and I'm very excited for our community to hear about your incredible work.
Thank you very much, Dr. Mengurian, for that introduction. Please bear with me as I share my screen here. All right. Okay, so I'm pleased this morning to be with you all and talking about closing the gap, improving physical health for people with serious mental illness, or SMI. I have no financial relationships to disclose. And I will be talking about major contributing factors to premature mortality for people with SMI, how to assess for some of the risks, and some of the available interventions to reduce adverse health outcomes for this population. So a few years ago, the New York Times had this striking headline, "The largest health disparity we don't talk about." This was by a physician, Dhruv Kular. And what he was talking about was the problem of premature mortality among people with SMI, particularly schizophrenia, who die 8 up to 25 years earlier than the general population. Even more of concern is that this mortality gap has been widening over the last decade. This graph shows standardized mortality ratio of patients with schizophrenia compared to the general population. So this is the ratio of observed deaths in the group to expected deaths in the general population. And this has increased from a little under 2 in the 1970s when this problem was first being documented to nearly 4 in the 2000s. So a first question is, what are the causes of death? This is a large study from Canada, and on the right shows major causes of death for people with schizophrenia. We can see standardized mortality rates again. And that yellow line shows that about 75% are dying from cardiovascular disease, including stroke and myocardial infarction. And the second leading cause of death is cancer, which is to say that most people with schizophrenia are dying of the same things we all die of, but at much younger ages. And I'll also note that the suicide rates are higher in this population, though comprise only about 6% of the deaths. And there have been some improvements over the past 20 years, particularly in death due to cardiovascular disease, as you can see in that downtrending yellow line. But there's still a major gap between the graph on the right and the graph on the left showing individuals without schizophrenia. So there's much more work to be done. So next we can consider the major domains of predictors for premature mortality for people with SMI. And generally, they're thought to be 4 overall domains, though, of course, these are overlapping and interacting. So starting on the left, we can consider social risk factors, which include unstable housing, poverty, and involvement with the legal system. Then moving over to health behaviors, there are high rates of smoking, poor diet, and sedentary lifestyle. Third, there are clinical and systems factors. That includes inadequate screening for common medical conditions, which can lead to delays in diagnosis and treatment. It also includes fragmented care systems between mental health and the rest of the medical system, fragmented electronically, financially, and geographically, which can make it really hard to access clinical care and appropriate services. And finally, there are the adverse side effects of medications, particularly second-generation antipsychotics that contribute to an elevated risk of metabolic syndrome. And then an undercurrent of all of these lies stigma, which affects perhaps different opportunities, different types of medical care access, and medical care options for people with SMI. So I have done work in all these domains. I'm going to highlight just a few of the studies in certain domains for this morning. So I'll start with clinical and systems factors. This study looked at metabolic screening and HIV testing in community mental health centers here in San Francisco. The motivation for this study was evidence of low rates of screening for diabetes and cholesterol for people with SMI, despite the APA/ADA guidelines recommending annual metabolic screening for those on second-generation antipsychotics. There's also evidence of low rates of HIV, Hep C testing in this population, though they have an elevated risk of infection. So the study considered the mental health clinic as a possible entry point for providing primary and preventive care. And the project was done in collaboration with Citywide Clinic in the San Francisco Behavioral Health Network. And the feasibility part of the study was recently published in Psychiatric Services. So we set out to test the effectiveness of a pilot intervention to increase metabolic screening and HIV testing for people with SMI in a community mental health clinic setting. The study used a quasi-experimental design comparing one clinic that received the intervention to usual care at the remaining mental health clinics. And the intervention was modeled after collaborative care, which is shown in the picture on the right. So this involves a mental health consultant, a care manager, and a stepped care approach to providing mental health care access in primary care settings. The intervention used a reverse integrated approach to introduce primary care practices into mental health settings. And the intervention consisted of 4 components adapted from the collaborative care model. First, panel management, which is a population-based way to have an overview of who's missing screenings and due for screenings. Second, team-based care, including a primary care consultant and support staff. Third, training and protocols around the screening and testing. And fourth, a stepped care approach for follow-up and treatment if higher level of care was needed. And then we examined the pre versus post-intervention rates of screening and testing. So what did we find? We evaluated rates of A1C and lipid screening, as well as HIV testing before and after the intervention. The red line shows the intervention site and the blue line shows usual care. So starting on the left, A1C screening rates did increase at the intervention site, but after adjustment, this wasn't statistically significant. Lipid screening rates increased significantly after adjustment, and HIV testing increased from about 1% to 16%, and also demonstrated that HIV testing is really not being done routinely in a mental health clinic setting. I will note that these axes top out at 30%. So these rates of screening are still far below optimal, which per the APA guidelines would be 100% annually for A1C and lipid screening. And this really suggests to us that a more intensive intervention with more infrastructure likely would be needed to really have a robust response here. Also, this was done at a single site using a quasi-experimental design, which has some limitations. However, we did see some modest gains in screening for lipids and testing for HIV. Yet, based on these findings and other studies of similar types of reverse integration, it appears that more intensive intervention is needed. We'll really need to think about how to bring in financial incentives and tie those to quality metrics and infrastructure to move this needle. We'll also need to do additional research to understand and evaluate barriers at the patient, the provider, and systems levels. So I'd now like to move on to a different study. This one is based in an integrated healthcare system that has payments, electronic health record systems aligned, and to look at the role of psychiatrists in treating a specific health behavior, which is smoking. So we know that people with SMI have very high rates of cigarette smoking. This graph on the left shows SAMHSA data from 2017, and it shows that people with SMI have about twice the rate of smoking compared to adults without mental illness, 35.5% compared to 17%. And among adults with schizophrenia, the rates are even higher. Over 60% of people with schizophrenia report smoking. And smoking is a major risk factor for early mortality, as well as high rates of cardiovascular disease and cancer. And historically, people with SMI were excluded from smoking cessation studies, so there was a limited evidence base around treatment options. And that might have contributed to some misconceptions that stopping smoking would worsen mental illness, that this group of folks is not interested in quitting smoking, or that treatment is ineffective. But fortunately, there have now been several robust studies demonstrating that pharmacotherapy and counseling are effective for smoking cessation for people with SMI. It also seems like pharmacotherapy may play an even more important role, potentially because of the role of nicotinic receptors in schizophrenia. So pharmacotherapy is needed alongside counseling. Just briefly, why such high smoking rates? As I mentioned, there's some evidence of nicotinic receptor involvement in schizophrenia, but there are also major social determinants of health, including historically targeted advertising in low-income communities, and that includes people with schizophrenia. There also were smoking breaks or smoking itself allowed on inpatient units and cigarettes provided as incentives, the thought being that that helped with symptoms. And there continue to be beliefs that smoking might be a lesser evil compared to other substances, and that stopping smoking would exacerbate symptoms. So this was work done in partnership with Julie Schmidt-Diel and others at the Kaiser Permanente Division of Research. And we focused on a particularly high-risk group of patients, smokers with type 2 diabetes who have elevated risks of cardiovascular complications. And we compared those with and without SMI in terms of their use of smoking cessation pharmacotherapy. And this was published in Addictive Behaviors. We used a retrospective cohort study design at Kaiser, and we looked at rates of prescription fills for nicotine replacement therapy, bupropion and varenicline, as well as the types of providers who were giving these prescriptions. So first, we found that smokers with type 2 diabetes and SMI had a higher uptake of smoking cessation pharmacotherapy. They're about 80% more likely to fill these prescriptions than the non-SMI group. And we were excited to see this. This does align with some previous work that finds that people with SMI are maybe more likely to adhere to diabetes medications when they have both SMI and diabetes, perhaps because they're familiar with taking daily medications for a chronic illness and managing that illness. We next looked at who was providing these prescriptions. And in the non-SMI group, not a big surprise that primary care providers wrote most of the prescriptions. But in the SMI group, only 8.8% of psychiatrists and psychiatric providers provided the pharmacotherapy, despite frequent contact with psych providers in this population. So to us, this reveals an opportunity for psychiatric providers to be more involved in offering smoking cessation pharmacotherapy. I will note that this is Kaiser, which has close connections between primary care and behavioral health, so might be limited in generalizing to other health systems. But in conclusion, we find that this demonstrates an opportunity for more smoking cessation interventions in mental health settings, and that psychiatrists are particularly well-positioned and uniquely positioned to offer motivational interviewing and pharmacotherapy to folks with SMI, who we see likely more frequently than primary care sees them. And this poster on the right is from Massachusetts Department of Mental Health. They have an initiative solely focused on smoking cessation for people with SMI, have really kind of taken up the torch on this issue. And San Francisco has the opportunity to take the lead in this as well. All right, so finally, I'll turn to a study in the VA, another integrated healthcare system, looking at clinical factors. And this is work done with my research mentor at the VA, Dr. Amy Byers. And this is a study on multimorbidity and schizophrenia. So most previous studies have focused on single medical conditions, one at a time for people with SMI, as they have high rates of dementia, diabetes, Hep C, and respiratory diseases, among others. But older adults with schizophrenia may have multiple medical conditions, which is also called multimorbidity. And multimorbidity is associated with high costs of care and high rates of utilization. At the VA, in this study by Donna Zulman, vets with schizophrenia were found to be part of the 5% highest cost patients, who make up about half of all VA costs. So we set out to identify multimorbidity patterns among older adults with schizophrenia. And we looked at veterans ages 50 years and older who have schizophrenia over a 7-year period. And we examined the prevalence of 20 major medical and psychiatric conditions. We did this using latent class analysis, which is a machine learning method used to detect previously undefined groups. It's an analytic method that's been helpful in previous studies in our research group to identify what combinations of diagnoses may point to elevated risks, for example, for suicide. So here we were interested in trying to identify combinations of conditions that might point to elevated risks of mortality. So what did we find? Here, the y-axis shows prevalence of each condition. So this is not a trend line. We identified 3 distinct multimorbidity groups. And I'll draw your line first to that bottom blue line, which is relatively flat. This is the minimal comorbidity group. They had lower than 10% prevalence of all conditions other than tobacco use, which was about 12%. So this was really interesting to see that this is a group that actually appears quite healthy and may represent a type of successful aging. The second group is in black, and that's a group we call the high medical comorbidity group. And they had high rates, over 20%, for congestive heart failure, stroke, COPD, cancer, dementia, arthritis, renal disease, depression, and tobacco, among others. So this was a group that had quite high rates of several types of chronic medical conditions. And finally, we have this red group that we called the substance use disorders and related conditions group. This group had extremely high prevalence of alcohol, other drug, and tobacco use. And you can see that on the right side, that over 70% prevalence of these substance use disorders. And then high rates of other types of related conditions like COPD and Hep C, as well as chronic pain, sleep disorder, and high rates of PTSD and depression. So this was interesting to see that this is not a homogeneous group of older adults with schizophrenia. There actually are ways to identify subgroups that may have different types of clinical needs and also different types of elevated risks. We then looked at overall and cause-specific mortality across these multimorbidity groups. So again, in blue, the minimal comorbidity group had the lowest all-cause mortality rates. And the high medical comorbidity group in black had the highest all-cause mortality, particularly due to heart disease, cancer, and respiratory diseases. And then finally, that substance use disorders and related conditions group had the highest rates of mortality due to unintentional injury and hepatitis. And again, I think this may point to specific types of elevated risks. So the substance use disorders related conditions group may need a blend of addiction treatment as well as infectious disease care, for example, while the high medical comorbidity group may need special coordination with types of specialists, including cardiologists and oncologists. This is preliminary work, however. We just presented this work at the American Association for Geriatric Psychiatry meeting and received NIA funding to carry this work forward. We did identify distinct profiles of medical and psychiatric multimorbidity, comorbidity for older adults with schizophrenia with different patterns of mortality, and that these patterns may point to specific types of elevated risk. In the future, we'd like to do many more things. One is to investigate the minimal comorbidity class to try to understand, is this an example of healthy aging, and what can we learn that is supportive for healthy aging in this population. We'd also like to identify some of the underlying causal mechanisms related to mortality in this group and eventually identify targets for intervention. So today I've shown 3 studies that can point to opportunities for psychiatrists and other types of psychiatric providers to improve physical health outcomes for people with SMI. Premature mortality is a preventable disparity that we can address. And many people with SMI consider their psychiatrists as their primary sources of care or maybe first point of contact. So I highlighted studies looking at preventive care, like screening for metabolic and testing for infectious disease, smoking cessation opportunities where we could do more within the mental health clinic setting, and eventually thinking about delivering services where people are already being seen. So structuring care to respond to the complex medical needs of patients. And the work forward is to develop novel ways to build integrated care models and really create a person-centered healthcare system. So I have many thank yous, but especially to my research mentors, Dr. Christina Mangarian and Dr. Amy Byers at the VA, as well as my current fellowship program and the VA, RRTP, and APA funding. So thank you very much, and I'll be happy to take questions.
Okay, outstanding talk, Dr. Hwong. Are there any questions from the audience? We have about 5 minutes. So as Gina texted in the chat, if you have a question, raise your hand and then we can unmute you. Okay, Demian. I think I can do this. I might be able to. I don't know. Gina, you may have to help me. Let's get Demian Rose and then Mateus. There.
Got it. Okay, I had to agree to unmute. Okay. Hi, Alison. Thanks for this. This is great. Very understudied. So I'm glad that you're taking such a close look at it. Based upon the hypotheses for premature mortality, of course, medication side effects is one that, in my experience, is not well studied. I'm wondering, did you notice any difference between any groups in antipsychotic load? And so person years of antipsychotic exposure or dosing or type of antipsychotic or anything like that?
That's a great question. For example, the multimorbidity study, is that?
Yeah, just in that class analysis, did that feature in any of the groups as a factor?
So we have not yet looked at medications, and that is a future next step for sure, both to look at polypharmacy and what combinations of medications might elevate risk, as well as what medications might be protective. So that's definitely on our to-do list.
Great,
but
look
that's
forward
not
to
something
it.
we've looked at yet.
Excellent, thank you. And Mateus?
Hello. Hi, Dr. Hwong. Thank you so much for your talk. I wanted to ask a question that it is a little bit adjacent to the topics you touched on today, and it is about premature mortality with SMI and COVID. I recently was involved in a project where they were analyzing higher mortality rates for people with SMI in Chile. I wanted to know if you have any thoughts on that, if you've seen data on that in the United States or also other places in the world. Thank you.
So that's actually work I haven't done. I think others, Dr. Mangurian may know of, and in our lab, they have done that. I have seen some of the studies on elevated rates in the SMI, elevated COVID death rates in the SMI population. Then that SMI is basically the top or one of the top health risk factors for death from COVID, and should be kind of noted as such, elevated as such, and people with SMI should be prioritized for vaccination, boosters, and other kinds of protection. But I haven't personally done some of that work. I think Dr. Mangurian has.
I'll just briefly say it's similar to what you mentioned in Chile. So here there's been studies in Connecticut and in New York looking at this, and there's higher rates of hospitalizations, and then if you're hospitalized, higher rates of death. And it is specifically for people with serious mental illness. I know that's why the work that was done at Citywide, one of the largest clinics that we run here in San Francisco, that's led by I think Fumi Mitsuishi and Carrie Cunningham, are both prior residency graduates, and they both focus a lot on keeping those patients safe and also getting them vaccinated, but there's more work to be done. And so actually one of the current residents, Alex Bizazzi, and I have partnered with the county and are looking at some of our internal data to see the adverse impacts of actually shelter-in-place hotels, because the data here seems to show that there's a lot of adverse impact of the shelter-in-place causing more opiate overdoses actually from the shelter-in-place. So more to come from Dr. Bizazzi on that later.
I also know it's, I think Christina might be
and then Jake, I think Jake's, you can speak, Jake, I think.
Yeah.
You look unmuted. Okay, let's take the last question from you.
Yeah, it's sort of kind of a comment, but just a thought about sort of future directions too. I'm very struck by the change over time in this mortality gap, and that it's actually gotten worse. And I think it's hard to, maybe it's better attention to some of these issues in the it sounds like maybe in the non-SMI population, but I think there's sort of competing theory to deinstitutionalization. We look at people, for example, ending up in the criminal justice system, which is something I'm very close to with SMI. And there's sort of this narrative that as the social safety net has essentially collapsed in over the last 30 years. People with serious mental illness have been more affected by that vis-a-vis sort of the socioeconomic impacts of this decline. And I think in that sort of a competing narrative with this idea that, you know, for example, the institutionalization is the reason people are ending up in jail. I think the same kind of principle could be applied probably to mortality, which is that, you know, we're looking at a collapse in our safety net, a collapse in not just the system of community mental health care, but also in, you know, all manner of systems for supporting people who need help, you know, essentially the welfare state. And so I just think also continuing to fold structural factors, and obviously I know you're very much a structurally minded person, but folding those structural factors into the analysis, because my hypothesis is that that's probably a very big part of the story as well.
Yeah, thanks, Jake. I'm going to stop my share because I know we're transitioning, but I'm really glad you brought that up. I think that's a hugely overlooked area, and maybe because it creates a lot of discomfort at policy and systems levels also. But that is actually the next project that Dr. Byers and I have applied for funding for, to look at social risk factors in particular, the role of housing instability, poverty, and legal system involvement, among others, in contributing to this mortality gap. So that's actually part of our next venture forward. Would love to talk more about that too.
Excellent.
Anytime.